All right, so welcome you guys to the good, the bad, and the ugly. Safety equipment utilized with equine movement. All right, so today we are actually focusing on equipment that is actually placed upon the patient. So we're gonna be looking at both helmets and gait belts. So I'll let you guys go over the objectives on your own time. We're gonna jump right into helmets. Put a helmet on at least one of your patients. Yeah, all right. How many of you are putting those helmets on to prevent head injuries, including concussions? All right, you might find out where that sentence is a little misleading later. All right, and how many of you have actually thought about not using a helmet because you're worried about damage that it might do to your patient? Okay, so we're gonna cover all of these aspects today, so let's get going. Let's start with the good. So why use a helmet in the first place? It's not like as medical professionals, it's common practice for us to be in the clinic and be like, oh, hey, yeah, I'm gonna throw this patient on the BOSU ball and I'm gonna put this helmet on. That's not typically something that we do. But we're not necessarily doing and utilizing the most common treatment tool, are we? We're utilizing horses. And when you look at horses, they've traditionally been used for sporting events and other activities where we can actually track a lot of data where head injuries occur. And so as a result of that, over the years, we've discovered that, hey, it might be a good idea to protect our heads and try to prevent some of these injuries from occurring. And so when we're looking at injuries that occur during horseback riding, 18% of all injuries affect the head. Upper extremity is actually the most common body part affected, and 18% may not seem like a whole lot. But when injuries affect the head, they tend to be much more severe. They are actually the #1 cause for hospitalization, and 60 to 70% of horse-related fatalities involve head injury. So even though they're not the most common injury, they do tend to be the most severe injuries that occur with horseback riding. A rider sitting on a horse, we all know this, several feet above the ground. Now you're gonna hear a statement out there and see it on websites a lot, that a fall from 2 feet can cause brain damage. Well, actually, when you dig down and look for actual studies to support that, that statement in and of itself is not supported. But I did find a research looking at when brain damage could occur. And what they found is in young children, those under 2, brain damage can occur from a fall 3 feet or less. But for those of us that are older and bigger, the fall must be at least 3 feet. Either way, it's a moot point because when you put somebody on top of a horse, that fall is gonna be greater than 3 feet. All right. So helmets can do a lot of good here. There are many, many studies out there that show that while head injury can still occur, we can definitely decrease the severity of the head injury that is occurring. Okay, so we can't totally prevent them, but we can decrease the severity. So I just wanted to repeat that because that's a very important thing to know. The United States Pony Club actually did a little study when they started implementing helmets, okay? So in 1983, they decided that all of their members and participants should have to wear helmets during mounted activities to try to keep the head safe. And then they tracked the data from 1983 all the way to 1990. And they compared that data to the data before 1983. And they found a 26% decrease in head injuries. So they felt that yes, helmets are indeed decreasing head injury rates. Now, after 1990, they stopped tracking the data. The reason being is because that is when ASTM stepped in and started regulating helmet use and certifying helmets for sale in the United States. There have been several cohort studies that demonstrate a 40 to 50% risk reduction when wearing helmets compared to not wearing helmets. And then finally, children in rodeo events that wear helmets, they still can have head injuries, but their severity scores upon admittance to the hospital and admittance to the ICU, much lower rates, okay? So we can see over and over again that it can reduce the risk and it can reduce the severity of injury. Now, fit and care matter. So helmet manufacturers actually come with a lot of recommendations for taking care of these things. You would think it would be pretty simple, but apparently not. And a lot of people don't bother to actually read the manufacturer guidelines. And what's really scary about that is if you don't follow manufacturer guidelines, the warranty is null and void. They cannot guarantee any reduction in risk, okay? So one thing you should be aware of is a lot of the different companies and brands that make helmets, they actually recommend that you replace that helmet every 5 years, no matter how well you care for it. Because over time, the materials that the helmets are made out of degrades, and they're no longer going to be certified to protect you after that time period. On top of that, equestrian helmets are designed and tested for single impact events. So what that means is once one of these helmets undergoes an impact, okay, it does not have to be a fall off the horse. If you're walking along down the barn alleyway and you're a klutz like me and you let that helmet go flying and it hits the concrete floor, guess what, guys? That was your single impact. If you're out riding on a trail and you forget to duck underneath a tree branch and you clip that helmet, that counts as a single impact. And once you've had that impact, that helmet is, once again, that warranty is null and void. It is no longer guaranteed to reduce your risk of head injury, okay? So be very aware of that. Now, there was a study done by Stanfield and Company, and they surveyed a whole bunch of riders out in the Northwest, actually. And they asked them, hey, do you have plans to replace these helmets after 5 years of use? And over 40% of respondents said no, okay? So quite a fair number there. They also asked, hey, after you've had an impact with a helmet, have you replaced it? This is a really scary one. Only 4.8% of riders replaced their helmets after having an impact, which means they were riding in helmets that the warranty no longer covered them, okay? So just be very aware of those things. The CDC point blank states that there is no concussion-proof helmet, but helmets can reduce the risk of head injury when fitted and cared for properly. So let's jump into what the fit and care guidelines typically look like. So I'm not going to read this slide to you, but I have everything listed out. That way you guys can refer back to it if you need to at a later date. Right here, I'm going to just zone in on the pictures because I think pictures are worth 1,000 words. All right, so in this first picture, obviously this is incorrectly fitted. Her helmet is way too low over the eyes of the rider. In this second picture over here, you can see the chin strap the V is not right underneath the ear where it needs to be. It's hanging way too low. And the chin strap itself is several inches gapping below the chin. When you have that loose fit, guess what's going to happen during an accident? That helmet's actually going to shift right off her head, okay? So it's not going to be effective at protecting her. In this bottom picture, you see a correctly fitted helmet. You get the nice V, you get the nice snug chin strap, and it's sitting over her eyebrows, which is where it should be, okay? Pretty straightforward. Helmet care. You're gonna check this regularly, just like you would any of your horse's tack. Look for any cracks, any signs of damage, any scuffs to the paint even. All of that matters. You're gonna clean it with warm water and mild detergent. Now, with the COVID pandemic, a lot of us could actually be in trouble here, because a lot of us were like, oh man, we need to sanitize everything. So we use strong sanitizers. Well, when you use a strong sanitizer on this, you degrade the material of the helmet faster. And that is not following the manufacturer's guidelines. Also, if you use UV light to sanitize these, you're also causing it to degrade and break down faster. They're not to be stored in direct sunlight, and you're supposed to keep them in moderate temperatures. Another thing is, I've heard a lot of therapists talking about, well, let's make the helmets fun for kids. Let's let them paint them and put stickers on them. Unfortunately, you're not supposed to paint or decorate your helmets in any form, Even stickers can go against manufacturer warranties because once again, by adding a different chemical to this surface, you can cause the material to degrade. All right, so we covered the good side of helmets. Let's cover the not so good. All right, so first up, helmets don't prevent concussions. We can actually start by looking at other sports and activities. We're not the only activity source. Equestrian activities aren't the only ones that include helmet use and have a high severity of head injuries, okay? So many other studies have been done, and when you look at all the studies for skiing and snowboarding and cycling, they've actually found a general trend. All of them prove that there's a statistically significant reduction in skull fracture rates, but there's actually no statistically significant reduction in concussion rates. Moving on to a few other sports, sometimes helmets and protective headgear are actually doubling the rate of concussion. So in boxing, there have been many studies done looking at protective headgear worn during matches versus no protective headgear. Now boxing, think about it, guys. We're talking these guys are hitting each other with their fists to the head. Ouch, okay? Definitely head injuries are happening, okay? In one of these studies, they looked at over 7,000 rounds of boxing with protective headgear on, compared to over 7,000 rounds of boxing without protective headgear on. So we're talking a lot of data points, and they found that concussion rate was double for the people that wore the headgear. That's kind of a scary statistic when you stop and think about it. Hold that thought for a second. Okay, so high school sports. There's been another study that looked at different high school sports, and they split them into two categories. They looked at helmeted sports and unhelmeted sports. And they established that helmeted sports have twice the concussion risk as unhelmeted sports. Another very scary statistic. And that brings us to football. So I could spend all day talking about all the research that has come out in the last 2 decades on football helmets. It's a hot topic issue because we have a lot of professional football players out there right now that they're having long-term brain damage. And it's because they've gotten concussion after concussion after concussion. And the football industry is trying to crack down on concussion protocol and stop this from happening. But the truth of the matter is their helmets are not protecting them in one bit. Sadly, they even did a study showing that leather, the good old leather skull caps from the 1950s, actually perform better on several impact tests than modern day football helmets. So we like to think that as we move forward as a society and as technology is advancing, that we're getting safer, that technology is keeping us safer. But sometimes we're actually finding design flaws where we're actually taking steps backwards. It's kind of a scary thing. All right, I saw a quick question in the back. I'll go ahead and take that right now. We're gonna get to MIPS helmets. It's coming up, I promise. All right, so we're gonna continue with helmets, the not so good, specifically the design flaws that I just mentioned. So one of the major design flaws that's coming out for equestrian helmets in the literature is that we've designed and tested these helmets for falls against hard surfaces. But the reality is most of us riders, when we fall to the ground, we're gonna be in a sand arena or out on turf or dirt, which has a little bit more give than asphalt or concrete. One study hypothesized that when they actually asked a bunch of riders that had concussions, that the majority of them would not have been wearing helmets. But what they found actually startled them, because actually 73.7% of the riders they interviewed wore helmets at the time of their fall. And they noticed a pattern, that a lot of those impacts occurred on turf or dirt surfaces. And so this led to some other studies being done. The next study that I'm talking about there, where 35% of helmets showed no signs of damage after an incident on turf, what they actually did is they found 20 people that had impacts to the ground, And some of them were on hard surfaces, some of them were on dirt, and they cut open their helmets to see what kind of damage the helmet sustained. And they found despite riders having concussions after hitting the turf or dirt, 35% of the helmets had absolutely no damage, which means the helmets took no damage. They transferred it all to the rider's brain. Finally, another larger scale study looked at 139 helmets from jockeys. Now we're talking racetrack jockeys, so they're always on turf or dirt. And they cut open those helmets, and they found that 46% of them sustained absolutely no damage. And what's scary here is not only were concussions recorded, but subdural hematoma and cerebral edema were noted. So we're talking more severe brain injury is occurring. All right, so not designed for turf and dirt. The next thing is they're not designed to protect the face. So something to remember with a helmet, okay, is that it's great for mounted activities, but 15% of head injuries actually occur during unmounted activities. And the majority of those occur to the face, okay? There's no face protection here. So a lot of people are like, well, that's fine. We'll protect people while unmounted. We'll just keep the helmet on. That's great if a horse kicks me in the back of the head, because right here, the helmet protects the back of my head. But if it comes at my face, there's no protection here. So I'm going to get injured. So there's a design flaw there as well. And finally, current testing standards, they don't accurately reflect real-world mechanisms of injury. So we're going to look at this on the next page in a little more detail of what the testing standards actually are. But just to give you a heads up, essentially all tests are done onto steel anvils, okay? We don't fall on steel anvils, do we? Okay? At least I hope we're not falling on steel anvils. Okay? So, and when they do the test, the impact duration is usually less than 15 milliseconds in time. We'll return to that number a little bit later. And then the max of force acceleration transfer to the head that is allowed is 250 Gs of force. So what that means is when they're testing these helmets, they actually test them upside down in this position, and they actually put a dummy head form inside of them with an accelerometer on it. And it measures the amount of forces of acceleration, okay, as it comes down and contacts that steel anvil. If the force to the head form exceeds 250, goes over that limit, the helmet fails the test. That batch of helmet is thrown out. It is not ASTEM approved. If the force remains under 250 Gs, it passes the test. And that batch of helmets can be certified as ASTEM. So, ASTEM is not the only company or group that certifies helmets. So they're the ones that do it here in the United States. They are in this bottom left corner right here. They only have two testing parameters that helmets have to pass. One is a drop onto a flat steel anvil. The other one is a drop onto an edged steel anvil. Okay? We've got up in the top, those are two European standards. And then finally, down here in the bottom is Snell. So Snell's a large independent company that has worked with sporting events helmets from a bunch of different sports, and they've created their own testing standards. And so you can get a Snell certified helmet. They're actually the ones that actually currently have the most different tests that a helmet has to pass. So for them, not only do they do the flat steel anvil, they also do the edge steel anvil, a rounded anvil. They do a spike test where they actually, this is supposed to simulate a horse kick. They drop a steel spike straight down onto the helmet, okay? And then finally, they do a crush test to try to mimic if, for some reason, you end up on the ground and a horse steps on you. Can that helmet protect your head? So, with modern technology, research has come a long ways. And this research in particular is actually a fascinating one. What these researchers did is they actually took real life accidents, of jockeys. And the nice thing about race tracks these days is they videotape just about everything. So we can get really good quality footage from multiple angles of accidents that occur. And what these researchers did is they found these accidents, they found all the footage, and they recreated the accidents and used computer programming to figure out how fast they were traveling at the time, how high up, how far that jockey traveled, what angle that jockey hit the ground at. And so they were, by doing all this, they were actually able to compute what's truly happening when that jockey's head is hitting the ground. And what they actually found was the forces to the jockey's head when they hit the ground were actually never greater than 130 Gs. So actually much less than what the helmets are designed to protect us for. And the duration of impact was always greater than 20 milliseconds. Now remember, all of this testing is always less than 15 milliseconds. So that means when the impacts are occurring, instead of being a really fast, hard drop on something hard, it's taking longer on those softer surfaces. It makes sense. There's more give to dirt and turf, okay? Now, the biggest finding that they pulled out of this research was that in testing, every drop is linear. Every single jockey's real-life accident was oblique, okay? So the forces are playing at different angles than what we're testing for. Don't give up. There is hope for future design. So Lori, here's your MIPS. All right, so as we get into this, we are getting better and better design. MIPS was actually created in the 1990s. It started for cycling and skiers. And essentially what it is it's a layer that goes on the inside of the helmet between the foam, the protective foam, and the pads that go against the rider's head. And that's just a quote directly from their website. But I think it actually works better if I show you guys a video. This one has rocking music. You may or may not hear it. So let's watch a video of how the MIPS system actually works. So as you can see there, the inside layer actually allows for some movement of the helmet on the head to try to deflect some of those rotational forces. Currently, there are 10 equestrian helmet brands that incorporate MIPS technology. And you can go to the MIPS website and actually look up what 10 brands those are. Coming down the pipeline from other sports, these aren't in any equestrian helmets yet, but some of the cycling helmets are trying to figure out ways to make the pads on the inside of the helmets themselves able to do the same thing. And so this particular company, POC, they created what they call spin technology, where they have made the pads sharing pads inside. Okay, that's what the spin stands for. But this is a very excellent video breaking down the theory behind it.
Rotational impact protection is necessary as the force required to cause head injury from an oblique impact is often much lower. We have created a design for spin pads to provide rotational impact protection based on the optimal location inside the helmet. By shearing in any direction, spin pads can reduce the effect of an oblique impact by allowing the helmet to move relative to the head. Spin pads have been created with innovative technology and introduce a new level of helmet comfort and protection. Spin, an evolution in rotational impact protection.
So once again, that technology is not yet available in equestrian helmets. However, I think it won't take long for a couple companies and brands to try to figure out how to make that work. All right, let's move on to the bad. Dun, dun, dun. All right, can they cause physical harm? We're gonna look at both acute accident-based injury as well as chronic use injuries. So first up, spinal injuries with horseback riding. Well, it can range quite a bit. The literature says that spinal injuries can account for anywhere from 2.4% to 14% of riding accidents. Now, we're going to look at the two most serious forms of spinal injuries today, spinal fractures and spinal cord injuries. So spinal fractures, actually, interestingly enough, most of them actually occur in the lumbar spine, and very few actually occur in the cervical spine. Now, it's believed that usually it's because when fractures are occurring in the spine, it's because that's the body part you landed on. And it makes sense. We land on our backs a lot more when we get thrown off a horse than we land on our necks. That being said, there's a disproportionate amount then of spinal cord injury because spinal cord injury is more commonly found up in the cervical spine compared to the rest of the spine. So why is that if we're fracturing down low? Well, a lot of people hypothesize it's because of the use of helmets actually creating more force, more shearing forces on the neck. One thing I want to caution us on here, the research here is really incomplete, you guys. We are tracking spinal cord injuries, but we have failed to track who has been wearing helmets and who has not. So at this point, we cannot establish full correlation or causation. We can only hypothesize what's happening. That's a very important fact I want you guys to remember. Moving on down to vests and collars. So especially in eventing nowadays, if you're going to do a lot of cross-country riding, people are wearing vests to try to protect this region. It has been shown to significantly reduce the risk of abdominal injuries. However, vests have absolutely no significant statistical impact on spinal injuries, and neither do the collars. Chronic use injuries. Okay, so we've got a couple different studies here, one done on show jumpers, one done on event riders. Both of them show a high amount of riders reporting neck pain. Now, this may not seem that bad, but when you actually look at a worldwide study looking at the prevalency of neck pain in those under 40, it's typically only at 12%. However, these two studies, by the way, both studies, the average age of participant was in their mid-20s, okay, so well under that 40 cutoff. Both studies, those show jumpers, 32%, not 12, 32% of them are reporting neck pain. And out of the event riders, 76% were having pain in the neck or a nearby region. Those are very high numbers and definitely establish that there's a correlation there, that those riders are definitely having significantly higher neck pain than anybody else. All right. Another study didn't want to look at pain. They wanted to look at actual changes to the cervical spine. So they actually jumped in and they looked at for arthritic changes. And they followed 32 jockeys over an average of a 13-year time span. And they compared them to 35 control subjects. And what they found by looking at their radiographs from the start of the time span to the end of the time span, 22 out of the 32 jockeys ended up with arthritic changes in the neck. However, in the control group, only 6 people ended up with arthritic changes in the neck. That is a statistically significant difference. So we do have a correlation here between riders that are competing and wearing helmets and neck pain and degeneration occurring. Now, I would love to see more research in this area, specifically into disciplines where helmets are not required, because every single one of these ones that have been studied, all the riders are wearing helmets because it's required. I'd be curious to see in disciplines where helmets are not required, if we're seeing the same rise in numbers or if it's truly because of the helmets, and move it from a correlation, because right now we've established correlation, but we have not established causation. All right, so we're not the only sport to be questioning, hey, are our helmets actually causing us damage? Okay, so motocross is actually something that's been very, very popular for several decades now. And children actually compete in motocross events. And the Children's Hospital of Philadelphia actually was like, hey, we're seeing a high number of children coming into us with spinal injuries after doing motocross. Now, this was done back in 2003. They got together this big conference, and they invited pediatricians, neurosurgeons, researchers, and a couple of experts from Snell, okay? They got all these experts together, and they all decided to start discussing what's happening here. Why are we seeing a high number of spinal injuries in these kids that are wanting to do motocross? And they all got together, and they agreed that the spine injuries were mostly happening in the cervical spine. And they started questioning, well, why is that? Well, by the age of 4, children already have 90% of the head size of an adult. However, their neck size is only 75% that of an adult's, okay? So there's a disproportionate growth of our neck compared to our head. And in this particular sport, motocross, at this time, didn't have dedicated helmets for their sport. They were using motorcycle helmets to keep the kids safe. Motorcycle helmets are actually quite heavy. And so all these experts got together and agreed that, whoa, we're doing damage here, because when you put a big, heavy helmet, and the heavier the helmet, the worse it gets, the more we're going to see those neck shearing forces and those bending moments, and the more likely that we're going to cause neck injury. And so all of the participants actually agreed that no children under the age of 6 should have a helmet placed upon them, nor did they feel that it would be feasible to create a helmet that would be lightweight enough and still not harm the neck for those under 6. Moving forward, they pulled on the researchers that they invited to the conference, and they pulled up their research to say, how do we know? How do we design motocross helmets to be lighter weight, but yet still be at an appropriate weight for the kids to handle them? And so some of the researchers they pulled from had actually done studies on ligamentous stiffness. Now, we're used to talking about ligamentous laxity because most of us work with patients that may or may not have ligamentous laxity. But stiffness is actually a measure of how much compression, tension, and bending forces our ligaments can take. Now, it's not ethical to cut children open to see how stiffness progresses throughout the lifespan. So these researchers did it to baboons and goats. And they wanted to see how stiffness develops throughout the lifespan. Because as we all know, babies don't have as much ligamentous stiffness as adults. That's why they can stick their toes in their mouth and go all bendy. You want an example? Go see baby Isla. Whereas I can definitely not get my toes in my mouth, guys. Okay? So they wanted to see how that stiffness increased throughout the lifespan, and then they estimated, based off of those 2 mammal studies, a range for humans. Okay, so they created this range, and then based off of that and another study that looked at what the ligaments of an adult neck should be able to handle weight-wise, which is 1.5 kilograms, they then tried to create a scale. Now this scale, I want to be very specific on. Don't get confused and think the lower limit is how light the helmet can be and the higher limit is how heavy. Okay, that's not the case here. It's all based off of the range of normal ligamentous stiffness. So this is the lower, if you're in the lower range of normal stiffness for that age, this is the max weight. Okay, so if we err on the side of caution, we should stick to that lower limit, right? So the max weight for what we can place on top of a 1-year-old's head is 0.23 kilograms. The max weight for what we can place on top of a 3-year-old's head is 0.35 kilograms. Now, especially for us Americans, kilograms may not be making a whole lot of sense right now. So I want to put this in terms we can understand with the equestrian helmets. This is one of the smallest, lightest weight helmets, equestrian helmets, that's ASTM certified, you can get on the market. Okay? It is 0.48 kilograms. So it is still too heavy for a 3-year-old to handle, based off of their research. This helmet, let's say you have a kid with a big head, okay? This helmet is 0.92 kilograms. Not even the 6-year-olds can handle that weight. Okay? And that is based purely off of what your ligaments can handle. Now, that's all well and fine, but 12 years later, still in motocross helmets at this point have been created and are being used. They looked at teenagers, and they looked at their cervical spines, and they looked for degenerative changes. And what they found is teenagers involved in motocross compared to controlled teenagers that were involved in other sports had significantly higher signs of degenerative changes in the cervical spine and the thoracic spine. Now, the interesting thing about the thoracic spine, it was all the upper levels, T1, T2, T3. So, even with the implementation of weight limits and trying to design the helmets to not put as much stress on the necks, we're still seeing neck degeneration. Why is that? Well, because there's more factors to consider than just ligamentous stiffness. So, let's look at a couple studies that have actually tried to track strength and what's normal for children compared to adults. So initially one study was done where they tried to figure it out, and they based it off of some tests that they did on people all the way from ages 6 to 20. And they created a linear equation, and then they regressed that equation back down using their data points, and they estimated that a 4-year-old would have about 54% of the neck strength as an adult. However, another study came along, and similar design, and actually a couple of the same researchers, but they used more test subjects, and they used a slightly wider age range, and they found some very interesting things. So for adults, neck circumference and strength and endurance, not correlated, but in children they are. The smaller your neck circumference, the weaker your neck tends to be as a child. The smaller your neck circumference, the less endurance the children's necks tend to have. So neck circumference is something we should be taking a look at. Age and strength are also correlated, as well as age and endurance. And I've got two charts here. So the first is strength. And so the dark gray is their actual data points. And what they found that it's not actually a linear line. It's actually an exponential one. And then the light gray are areas that they hypothesize that's where younger or older people would test based off of their curve. If you follow this hash mark right here, that marks an 8-year-old. An 8-year-old has 91% of an adult head size. And if we follow it up, that average 8-year-old has about 50% of an adult's neck strength. On this next one, if you follow that same 8-year-old line, they only have about 40% of the endurance compared to an adult. All right, so that brings us to precautions and contraindications. So when we're talking about putting helmets on our patients, these are things we need to be considering. We don't want to be doing any harm. So young age, a small neck circumference, okay? Weak neck muscles, shunts and reservoirs, they affect the fit of the helmet. If you're not getting that snug contact all the way around, technically that helmet is not fitted correctly, and it's not going to be adequate protection. Same thing with plagiocephaly. Misshapen head, you're not going to get the correct fit in that circumstance. Ligamentous laxity. Their ligaments don't have the stiffness to handle the weight. It's not a good idea to put an extra helmet on. And finally, bony abnormalities and any other abnormalities of the spine. So of course, when we're using equine movement, if there are things like scoliosis present, it's automatically a precaution, possibly a contraindication. You need to do further evaluation to figure out which it is and whether or not you're safe to use the movement. And then you need to figure out if it's safe to put added weight on top of that compromised spine. It may not be. And it really comes down to our evaluation skills and individually assessing each patient. For instance, if I have a patient with a neuromuscular-based scoliosis, but that scoliosis is actually affecting the cervical spine, it might be a mild enough scoliosis that I think equine movement would benefit for the symmetry, but I'm not going to want to add extra weight on top of it because then I'm going to stress that spine more. Yes, ma'am.
I just have another precaution that happened to us, and it was a Troxel helmet just like that, and on the outside it looked perfect. And it was at the right age, and the tape had started to come off, so my husband kind of took it apart. And the helmet looked great, no dents in it. The styrofoam inside was completely cracked from one side to the other. So it had one of your one impact, but nobody had known about it.
Yeah. And that's why it's important to rip off your liner and actually look at that foam inside. That's a wonderful point, Karen. All right, so summary of helmets. The good, they reduce the risk of injury, they reduce fractures and severity of head injuries, and technology is improving for rotational impacts. The bad, concussions still happen. So those of us that thought helmets were protecting against all head injuries, including concussions, we were wrong. Current testing standards don't accurately reflect real-world falls. There may be a correlation with neck injuries and degeneration. And finally, they don't currently account for ligamentous stiffness, neck strength, neck endurance, and even, I forgot to put it on here, neck circumference of the children that we work with. All right, so just a quick review before we move on to the next section. Just yell out the answer when you know it. Which of these is false? B, I'm hearing it, B, yeah, B is false. So if some of you are having trouble connecting the dot, concussions are a form of mild TBI, okay, and they're still occurring. All right, which of these is false? Don't be afraid, shout it out. B, yeah, B again. All right, so that brings us to gait belts, the good and the bad. All right, so gait belts. How many of you use gait belts when you're putting a patient on a horse? Okay, good. And how many of you think gait belts actually help you to control the falls so less injuries occur? All right, let's find out how accurate we are on this one. So the good. So first off, OSHA likes to state they're not lifting devices. If you have a completely dependent patient and you need to lift them, please use a mechanical lift. That's not what these things are for. All right, their intention is to actually help reduce the chances of a fall and control falls when they happen, especially when the caregiver or the therapist is trained in the proper use of them, okay? The next three researches are all saying the same thing, but just in different terminology, different words. Essentially, when you use gait belts, instead of having unassisted falls, you're having assisted falls, and falls occur less often as a result of that because you're there assisting the patient. Also, assisted falls, less likely to result in a serious injury than an unassisted fall. So it's pretty straightforward. Using one properly, you're going to just place the gait belt around the patient's waist. You want it to be nice and snug. You want to be able to get some fingers in there, but you don't want to be able to pass your whole hand through. That's a little too loose. It's not going to do you any good at that point. And essentially, you want to use that gait belt. If the patient starts to lose their balance, you have one hand on the gait belt, and usually you're going to put your other hand somewhere on that patient's trunk to help them stabilize. Okay? Don't use the extremities. Don't grab onto clothing. You'll go down. All right? In the event that you're using a gait belt and a patient is going to fall and there's no way to stop the fall, you use the gait belt to slowly control the fall, slow it down, control the descent so that injuries are less likely. Now that being said, gait belts come with their own precautions and contraindications. So obviously if you've had recent abdominal or back surgery, you're not going to want to put a gait belt over top of an incision site because it could pull on that incision site and open it up. So don't use it in those circumstances or place it at a level higher than the incision site. In the case of pregnancy, you never want to put a gait belt directly over a pregnant belly. Move that gait belt up, over through the chest area. For women, go over the breasts, under the armpits, okay? Hernias, same thing. Don't put a gait belt directly over a hernia. Always put it at a level higher than the hernia. G-tube or other tubes. You can also put gait belts higher than the levels here, or you can put additional padding to make sure that the gait belts don't catch on the G-tube. So there are many options. You can use thick sponges and you just place it right over that G-tube, and then if something were to happen and that belt shifts, that padding keeps it from pulling on the G-tube. You have many different forms. Like I said, you can use like a thicker sponge. You can use what we like to call fuzzies at our clinic. Some of these can actually attach to the belt. So if you have patients that like to pull on things, they can't pull them out. So there are ways to work with G-tubes as a precaution. Colostomy and ileostomy bags, obviously you want to go above the level of the colostomy or ileostomy. Fractured ribs or spine. If you have a patient that has fractured ribs and spines, please don't put a gait belt on them, and please don't put them on the horse. Okay, that's a contraindication for using equine movement anyways. All right, so injuries. Can injuries occur while using gait belts? You betcha, okay? So the most commonly reported for caregivers is injured backs and injured limbs. Shoulders is the most common complaint. You're walking with a patient, they suddenly fall, whoo, okay, you get your shoulder jerked, okay? Now, these injuries a lot of times can be prevented with proper body mechanics and handling, but sometimes even with proper body mechanics and handling, life happens and something happens and you get injured. It happens, okay? Risk to the patients. If you look at the literature of what gait belts have done to patients, usually it's just bruising and skin tears. The only time more serious injury occurs is if you ignored one of the prior precautions and contraindications. All right, not all gait belts are the same. There's been a study that came out recently, and they actually looked at different types of gait belts. And they, to make it easier on themselves, referred to this thicker one as a walking belt, and then this nylon one that's a little more traditional and old school as the gait belt. And they compared them, and what they found is that patients actually found the thicker, wider belt to be much more comfortable. They also found that caregivers actually like the thicker, wider belts with multiple handles because they felt like they could more easily use proper body mechanics. Furthermore, they went ahead and they tested compressive forces on the caregiver's spines during a sit-to-stand transfer using a gait belt. And they found that the wider walking belts actually resulted in less compressive forces at the lumbar spine for caregivers. Something to keep in mind when you're choosing gait belts. All right, so quick gait belt summary. They reduce the occurrence of falls. They reduce the occurrence of injury. Minor injuries can still occur, both to the patient and the caregiver. So, which of these is false? Say it loud for the whole group. Yeah, D, there's not just one style of gait belt. There's multiple, and you can find what works best for you and your patients. All right, guys, now we're getting to the ugly. Everybody buckle up. We're going to look at real-life malpractice cases against therapists and other health professionals in regards to both helmet use and gait belt use. Now, HPSO is, of course, an insurance company that some of us may be insured with, and they actually offer a whole data library of real cases that have happened to their clients. And so I searched that beautiful data bank, and I actually found there are absolutely no cases regarding the use or non-use of helmets. None. Zip, zero, zilch. Now, that being said, if you actually look at a lot of different insurance companies, they're going to tell you, it's okay to not put a helmet on, but please, please, please get a release. If you don't get a liability release and a helmet's not worn and there's a fall and your patient ends up with a head injury, you will be held liable. So please, please, please get a liability release if you decide not to use a helmet. All right, gait belt use. There's a ton of cases involving gait belt use. We're going to look at just 3 of them today. All right, so the first one, 64-year-old woman, she's paraplegic, she's at home, she's doing a bed to wheelchair transfer with a home health aide. The home health aide does not put on a gait belt during the transfer. She falls. They call the paramedics come and check her out. They don't find anything wrong. Now here's the corker. She's paraplegic. She doesn't feel anything below the waist. So she can't tell them whether or not she has pain. 5 days later, a different home health aide comes to the home to help her take a bath. They notice that, hey, your hip is really swollen and misshapen. They take her to the hospital. It turns out she fractured her femur. She requires surgery to repair it and 9 months in a nursing care facility before she can return home. So she goes after the home health aide for the fact that they tried to do a standing pivot transfer without the use of a gait belt. The aide tried to fight it, saying, well, it's the paramedics' fault because they didn't find the fracture at that time, so it must not have occurred then. Of course, that was thrown out. HPSO talked the aide into settling in this case because they knew they were going to lose. It ended up being a $310,000 settlement. Yes, Joanne?
So is it semantics? Because you said earlier gait belts are not used for transfers.
So gait belts are not used as lifting devices. They can be used as transfers, okay? They're not lifting devices. So in this case, with this woman, she can actually do some partial weight bearing. So they were doing a standing pivot transfer where essentially they get her up to standing, they pivot, they put her back down in the chair, okay? So she's actually partial weight bearing, so it's not a lift here. It is a true transfer, and the gait belt can be used in that circumstance, and in fact, often should be used, okay? All right, so next case is a 60-year-old woman, 4 weeks post-op total bilateral knee replacement. She's on her first day of outpatient therapy. She reports to the clinic. The PT does some evaluation. He decides to go ahead and get her on the recumbent bike. For those of you that don't know, a recumbent bike is one where you're actually sitting and your legs are out in front of you. She cycles on it for 10 minutes. She's feeling a little bit weak afterwards. She actually requests assist to get off the machine. But the PT is like, I saw you walk in here with a single point cane. I think you're moving pretty good. I want you to go ahead and try to get off the machine by yourself. As she's swinging her right leg up and over to try to get off the machine, her foot gets caught and she twists and ends up falling on her left knee. Okay, the PT and his student go to her aid. They get her upright on her feet. They give her a walker and they tell her, go ahead and try taking a few steps. They essentially want to see how she's moving after the fall. She takes a few steps. She's in extreme pain. She stops and tells them she can't continue to go on. The PT student very smartly grabs a chair and puts it behind her. At this point, they still have not given her a gait belt or any aid or assist. He barely gets the chair behind her in time before she passes out and falls into it. Okay? At that time, they wait for her to wake back up. They get her back woken up. They send her home. So she goes and reports into her surgeon a couple days later because she's in pain still. It's hurting. It ends up that it was a full tear of the left quadriceps tendon. Has to be surgically repaired. Now that in and of itself is bad enough, but then she has complications with a DVT and has to have another surgery to have that removed. Then the amount of scar tissue from all the surgeries accumulates so much, they have to put her under anesthesia again and do a scar tissue manipulation. So she ends up with 3 additional procedures. The poor lady never regains more than 90 degrees of knee flexion, no longer is able to do her job, and her surgeon declares her permanently disabled. Okay? So her team went after the PT, and they said, okay, when she requested assist off that machine, you should have put a gait belt on her and helped her transfer off the machine. Okay? That was their number one claim. Now, this PT decided to try to fight it, you guys. This was a terrible decision. The jury sided with her. They agreed with her. They said, should have put a gait belt on her and helped her off the machine. Then when they decided to try to make her walk, should have had a gait belt on her at that point. You've already had a person that's already had one fall, and here you're asking them to move again? High risk of another fall. Should have had a gait belt on and a hand on her and guarding her at that point. If it weren't for the PT student, she would have had a complete second fall to the floor. Okay? So the jury was not happy with this PT. They were also not happy that the PT didn't call 911 after she passed out from the pain. Okay? So in this case, the total incurred was over $650,000. All right, the next case, 49-year-old female recovering from a motorcycle accident. She crushed her spine, she fractured vertebrae, she fractured her wrist, she spent a very long time in the hospital. She goes to a rehab facility, spends 5 months there. All right, she's making gains, but she's still not fully independently weight-bearing on legs without also doing some weight-bearing through arms. So the PT sets her up for an exercise where she's going to be partial weight-bearing through the left leg. She's going to have one arm on one exercise piece of equipment, the other arm on another, and be partial weight-bearing through her arms. And then she's going to put a ball underneath her right foot and roll it back and forth. The PT puts a chair behind her in case she needs to sit down, and the PT is actually on the floor in front of her in case the ball rolls away. Okay? Now, a fall actually didn't occur here. What happened is the patient got tired with her right leg. She told the PT she was tired. The PT in this case told her, go ahead, sit down. All right? The problem is she's still not fully weight-bearing on her legs, guys. She's taking some of that weight. And right now, she's on 2 different pieces of exercise equipment that she's sandwiched between. She lets go of them and puts all of her weight on her left leg. Okay? What happens is instantly she felt pain. Turned out to be fractures in the metatarsals of the left foot. She didn't fall, luckily, but they claim that because of the improper weight shift, that's why the fractures happened. In this particular case, the plaintiffs went after the PT because they said it was a good exercise for the goals they were working on. But the problem was the PT's implementation. They claim that the PT should have had a gait belt on the patient, should have been standing next to the patient to help guide weight shift, especially because she wasn't supposed to be full weight bearing on lower extremities only. And that it should have been done in the parallel bars where you can more evenly distribute weight between your upper extremities instead of in between 2 pieces of exercise equipment. And so they went after them. Eventually, they ended up settling for over $175,000. In the meantime, the PT also incurred over $17,000 in legal expenses. All right, so let's do a quick review of these real-life liability cases. Which of these is false? A. So no therapist has been found liable for a patient not wearing a helmet. Okay. Let's get to real-life case studies. Helmet and gait belt use. All right, so for each of these cases, I'm going to just introduce the information to you. You may ask me additional questions if you want more information, totally appropriate. and I will answer the best I can. And then I want you guys to tell me, do you think I should put a helmet on? Do you think I should not? Do you think I should put a gait belt on? Do you think I should not? Okay, so we've got someone saying a helmet. Anyone saying no helmet? Yeah, so in this little guy's case, yeah, it would. It would depend on that. You need to have that dynamic assessment, okay? What about gait belt? Anybody have a differing opinion? Go for it.
Sounds like almost when in doubt, use the gait belt, right? Or it's default to the use of the gait belt in everything. It's not contraindicated.
Exactly. When it's not contraindicated, you should be wearing a gait belt, especially if anything taught you from those liability cases. If you're going to be in a fall risk situation, which I would say putting a patient up on a 1,000-pound animal with a mind of its own is definitely a fall risk situation. If you're going to put a patient up there and you don't have a gait belt to help control a fall, you will be found liable. So unless it's contraindicated, yeah, always put one on. Karen.
Yeah, and I think this is fabulous, and I completely agree with you. I'm reminded of a talk at the last Hippotherapy AHA conference where the keynote speaker was fabulous, and he really challenged us to consider not using gait belts because it changes the psychological aspect of the client and makes them dependent, changes their gait, changes how we feel about them, which I found really interesting.
So I actually will fight that a little bit. So I've played around with PT students that I've had. Because I've had a lot of people say, yeah, well, it changes it when you put a gait belt on somebody. It feels different, and it changes the movement and all of that. So I've had PT students where we've played around where they focus on feeling the movement of the horse and with the gait belt and without the gait belt. And I ask them, okay, did the movement really change any for you? And they were like, no. And then I play around with your higher level patients and people handling the gait belt. It takes skilled handling. So we played a game. Am I holding your belt? Am I not holding your belt? Where I'd let go, and sometimes I would hold it. And I'd see if they could identify a difference of when I was holding that belt and when I wasn't. And you know what? Those students cannot tell. If you take the time to develop skilled handling, your students and patients won't be able to tell that whether or not you have a hand on that gait belt. And what Tim Studer was talking about was the traditional gait belt where you always feel it because your hand's tucked in between the belt and their body. That's the advantage of using these wider base gait belts with the handles. They don't know if my hand's there or not unless I'm actually truly need to give them additional support. Yes?
Well, in terms of the psychological impact of wearing a belt, and feeling all this, life wearing a belt, I think you need to consider that this individual probably still has a delayed reaction time. If you're going to have to, this person's going to go into a fall, their own protective responses are not going to be good, and having that belt mitigates that situation. And I think in the big picture, I don't think you can afford to take a chance and not have a belt on this person. You need that.
Yes, Gloria.
So with my answer, when you said gait belt, I did imagine.
You went to this one. Yeah. But remember, we have different options.
A loop one, I don't call it, I don't really call it a gait belt.
Well, you can do what that research did. They called this a walking belt.
I would use one of those always with a child on a horse. But I don't know that, I don't like the other one.
And that's okay. It's okay to say, I don't like that style of gait belt. I prefer this one. That is okay. So for this young gentleman, because of his weight and size, and then of course the 13 out of 24, that's on the dynamic gait index. So that's looking at balance during walking tasks. And that's a low score, you guys. So he's at a high fall risk, okay? With this little guy, yeah, I used a gait belt and I used a helmet, okay? I felt both were appropriate in this situation. So now we're gonna jump on to the next case, okay? So 8-year-old girl, muscle weakness and atypical patterns following an in utero incident. So I'm gonna actually tell you what this in utero incident was. Her family was out for a walk on the 4th of July. Mom was 36 weeks pregnant with her at the time. The weather suddenly changed and the family was struck by lightning. Now, she was in utero, which means she was surrounded by amniotic fluid at the time. So she took a lightning strike while surrounded by fluid. She was delivered the next day, and she survived, okay? So quite an interesting case. Currently, we're working on sitting balance, and she's averaging about 30 seconds with contact guard assist. We're working on walking with assist. She can take about 20 steps with max trunk support and 10 steps with moderate. And she currently has a G-tube for nutrition. What do you guys think I did in this case? Okay, speak louder. Start with you. Yep, exactly. Anyone disagree with that?
I have another alternative. If you're also working on core strength awareness and everything, the abdominal binders, and I was thinking like the Mary Mastery courses, abdominal binders are another great
So,
tool that I put under a gait belt.
as a pelvic health person, I actually am against using abdominal binders while on the horse because it actually puts too much pressure on the pelvic floor. And we're already putting high demands when we're putting patients on horses and having all that movement through the pelvic floor, okay? So what about a helmet? What do you guys think? I'm seeing some shaking of heads going no. All right.
She only has a 30 second. She only has a 30 second with contact guard assist.
Yeah, so she's only sitting for about 30 seconds. So probably can assume head and neck control may not be that good, right? And I've already stated she's pretty weak. So yeah, the recommendation would be no helmet. Now, somebody once asked me about what about her ligamentous stiffness? Her ligamentous stiffness is perfectly typical for an 8-year-old. Does that change your opinion any?
The other thing that concerns me is the atypical tone pattern. So what kinds of excessive ancillary compensatory movement there is that.
Exactly. So she's got fluctuating tone patterns. So there are times where she goes rigid and there are other times that she just flops. Okay? All right. So I think the consensus here is no helmet, yes gait belt, but with modifications for the G-tube, okay? Now, I went ahead, yes.
Do you have any research about atypical development and helmet, like injuries or long-term stuff? Because I have a lot of kids with adaptive equipment or doing other activities that require helmets, and we actually have a certified helmet that's under a pound that we use. So there's really good hit, and you know, they're not getting a lot of these high impact things.
So,
For a risk versus benefit type of situation.
I don't have a lot of good, statistical research on that, but let's take a look at this actual case. So I put one of our smallest, lightest weight helmets on her, just so we could see what would happen, okay? And I want you to watch what happens, and you tell me if you think this did damage.
How much did that helmet weigh?
So that one weighs about 0.5 kilogram. So just a tiny bit over a pound. Okay, did I do damage? Yeah, you guys, I hurt my patient. I did a no-no. I wasn't protecting her with that helmet. I did damage when I put that helmet on. Did you see the way her head whipped to the side a few times? That's whiplash right there. That's up next. Thank you for asking. All right, so here's the next one. So I also like to point out that helmet whipping around, did you notice how many times I had to reach up and stop her from having a fall? Okay, we ended up max assist in that first video. So now watch this second one. Okay. Do you guys see the difference there? Yes, Gloria.
If you're on a facility where they required helmets regardless, and you had even a light one and the child couldn't control it, would you consider using like a soft cervical collar to prevent going too far into the range?
I would not actually, because if you're using, well, if you're using something, it depends on the softness that you're talking about. Anything rigid I wouldn't use, because anything rigid, of course, is just going to transfer the movement above and below that point and put more shearing forces there. So I wouldn't use anything rigid. I have used like a very soft little like baby boppy pillow to give just a tiny bit of neck support. I have used that before just to make sure they don't go so far into it. Exactly. So yeah, I actually would agree with you there. Yes.
I was gonna say, I have a couple of kids that present similar to this, but with that helmet that's under a pound and then actually giving them some sort of elevated surface to push off of, I actually see a lot more upper control because they need to have that weight bearing through the arms. I'm actually getting a lot of good function through there. So I actually don't even see a lot of what you see even without the helmet, even though I think it's a really good video to show, you know, what added weight can do.
Exactly.
But it is possible, you know, if you do believe to use the helmet, that there are helmets out there you can use and still be effective.
So in this case, doing something lightweight like this one, okay? And with this particular patient, even though this is a lighter weight helmet, do you guys think she would still probably get too much? Yeah, it would still be too much. So that's actually a perfect example of it's got to be a case-by-case basis. You've got to really evaluate what your patient can and cannot handle. Can they handle that lightest of helmets that you have? It may be a yes. It may be a no. Okay? So let's go ahead. Let's move on to the next cases. Okay, patient A. So both patients in this cases, we're going to look at two side by side. We've got patient A. Both of them have Ehlers-Danlos syndrome. So patient A is 8 years old. She also has juvenile arthritis. She's got no cardiac issues, history of multiple dislocations, all happening at the shoulder. Last one occurred 2 years ago. She's got hyperextensive joints. Her knees, hips, and shoulders are the most affected. She's got recurring pain and swelling in the knees and hips. Her strength is within normal limits for her age, and she has central obesity. What do you think I did here? So central obesity. So it means that looking beyond just the BMI and the weight percentiles that the CDC recommends for tracking children's obesity, central obesity means that a significant portion of her weight is all around the belly. So we're looking more at like the hip to waist ratio versus strictly BMI.
How's head control?
Her head control is excellent.
And the juvenile arthritis, is it, how many joints are involved?
The knees and the hips.
And how's her ligamentous laxity?
Wonderful question. So yeah, EDS, ligamentous laxity. So when I did a thorough manual examination, she actually had no laxity within the cervical spine.
So that sounds like she could tolerate a light helmet.
Okay, tolerate a light helmet. Anybody disagree?
For the case, to support your case with this presentation and what I've known from, you know, the theory out there is that in how we utilize equine movement, an emergency dismount should be as safe, if not safer, without a helmet. So if there's a possibility to create damage, especially with arthritis, you know, potentially she could benefit from that.
So her arthritis is only in her knees and her hips. So do you think the helmet would impact that?
In normal individuals from the studies you showed before, potential chronic use.
Exactly. This is something we need to be questioning, and I'm so happy you're questioning it. All right, Matt.
How are you testing your ligament stiffness? Are you doing like cervical PAs or?
So I actually go in and first I ask the kids to, if they're capable, to just do range of motion. I first want to see how just that neck moves as a whole. With her in particular, she was capable of strength testing, so we actually did some strength testing to see how strong she was in that head and neck region. And then, I actually go in and I do not just PAs along the spinous process, but I actually do a number of different joint accessory evaluations. We're going down the facet joints as well. I play around and I see, okay, how much movement do I get out of these vertebrae? And I shift them in all directions. So what I ended up doing with this case is I actually chose to put a helmet on. I chose to put a helmet and a gait belt on. The reason that I chose a helmet is because she's 8 years old, but she has central obesity. This particular girl weighed over 80 pounds. So yeah, I'm gonna use the gait belt to help control the fall. But guys, 80 pounds is a lot, especially when it's coming from up above you, okay? And so I put the helmet on just to have that extra layer of safety in case I failed in my body mechanics and I failed to adequately protect her during the fall. Just having that extra layer of protection. I felt that after thoroughly evaluating her neck, seeing how strong she was, seeing that there wasn't any laxity in her cervical spine, I felt confident in going ahead and putting a helmet on her.
And would you also consider the amount of time she's on?
Yes, exactly. Well, the faster you're going to fatigue. Remember that endurance. An 8-year-old's endurance is only 40% of that of an adult. So I have no concerns about throwing a regular size riding helmet on an adult and sending them out on a horse for an hour. For her, I'm not going to want to use that movement and that weight for a full hour. Now, am I? So there are lots of variables and things to consider in this case. Let's move on to patient B. Same diagnosis, Ehlers-Danlos syndrome. She's 6 years old, familiar history of excessively stretchy skin and joint dislocations. Actually, at the time I started seeing her, her mom had just recently dislocated her ankle, okay? Hyperextensive joints, personal history of abnormal heart rhythm, history of frequent neck pain, as well as occasional back pain, knee pain, and hip pain, history of spraining ankles, and weakness with muscle testing. What do you think I did here? No helmet. This one's actually kind of a no-brainer, right? So what's one of the factors of why I chose no helmet? Yeah, I'm hearing a bunch of them because there's a bunch of them. There's ligamentous laxity. There's weakness. She's got a history of neck pain, okay? It's a terrible idea to throw extra weight on top of that, okay? Because I'm actually just going to exasperate and make that neck pain worse. All right, would you guys like to know anything additional about that case?
How'd she do?
She did really well. We actually utilized the movement and we actually did neck stabilization exercises while on the horse. And she improved to the point where I discharged her because she was no longer having any neck pain and or back pain or knee pain or hip pain. She got to the point where her joints were feeling good. The only thing that she was still having issues with was GI distress, which is actually very common with Ehlers-Danlos syndrome. All right, any other questions? Okay. So let's go ahead and jump into some other discussion points here. Which safety equipment has a more favorable risk to benefit ratio? Helmets or gait belts? What do you guys think? Gait belts, yeah. So we know for sure that they definitely reduce the likelihood of a fall. And when a fall does occur, they reduce how serious the injury is. On the flip side of that, there's not a lot of contraindications or precautions. There are some, but a lot of times when we're looking at those contraindications, fractured rib or spine, those are also the same contraindications that we wouldn't be using equine movement anyways, would we? All right? So yeah, the gait belts actually come out favorably. So which one would you guys choose to be your first line of defense for your patients? Shout it out loud. Gait belts, yes, gait belts.
Safety belts. And I know that created a misnomer because we don't talk about somebody on, but as, you know, it's interesting listening to the confusion about them.
Yeah, I mean, gait belts have a terminology issue. I think we're all familiar with that by now. All right, so can we set clear guidelines? This is a discussion that I'd like to start generating for us. Can we set clear guidelines of when to use a helmet and when not to use a helmet? What do you guys think? I'm getting a yes from the back. I'm getting like a flow sheet from Gloria. Yeah, it could be something flow sheet like. What do you guys think?
But then we have to, I mean, if you look at PATH,
Right.
they require.
Yes.
Even if we had a flow sheet, we can't get around that.
So in that case, for those working at PATH facilities, PATH recognizes that helmets actually could be detrimental in some cases. They're actually really good about that. So even if you're working at a PATH facility where it's their policy that a helmet goes on everybody, part of their policy is an alternative helmet policy. So for those people that are working at PATH, they can maybe determine, like that one girl in the video we saw, she can't handle any additional weight on her head. Not really. You could put something like this on, and it complies with their alternative helmet policy. And so you could put something super lightweight like this on. It's not going to significantly add any weight. It's less than an ounce, you guys. And so this would be safe to put on a patient like her if you're at a PATH facility. And you're still complying with their policies, but you're not going to be giving her whiplash, okay?
So, am I correct in saying that the alternative helmet policy also acknowledges the inability to tolerate the use of helmets?
Yes. Yes, I believe so. It does acknowledge inability to tolerate. So if you're working with a kiddo with severe sensory issues that they just can't handle the sensation of the helmet, it also accounts for, oh, Joanne's shaking her head. Okay, yes, if you want to read that out, there's no, okay. Joanne is saying there's not, and what did you find over there?
Give me a second.
And the other piece of it is it also depends on who your insurance carrier is. Because if you're working with Markel, helmet is not negotiable. The alternative helmet guidelines are fine.
Uh-huh. But there has to be a helmet. Okay, so there we go. So for PATH, there does have to be a helmet, even with sensory issues, it sounds like. Yes, okay. Yep, and
Or you can call it multi.
And we would suggest, I know that with our, because we still use Markel, and when Lawrence had a discussion with our insurance person, they've said when push comes to shove, if they're always going to stand behind you, regardless. So it's helpful to have those forms signed, obviously.
yes.
But so it doesn't necessarily, even though that's their statement, they still will get behind you as their client to back you. But I mean, that's just the talk, right?
But
Yes, no, it's good. This is good.
A little bit louder.
with any insurance company, Markel included, they will stand behind you. They will not renew you.
Good.
And any insurance company you go to in the future will always inquire, have you ever had an instance with anybody in the past? And the chances are probably pretty good that they will
Good to know. Thank
deny
you.
you as well.
So should, I mean, if we did something like that, it would be when to use a typical helmet and when to use a alternative helmet. Because it sounds like we should use a helmet because of the different situations like that.
Yeah, that's something to keep in mind for our flow sheet, that some people are going to be limited potentially with the facility they work at, and not just the facility location, but also certain states are going to require the use of helmets. So that's where your location in general is going to matter, as well as policies and procedures in your area. Like Joanne pointed out, if you have Markel as your insurer, you should probably be utilizing some form of a helmet. Now, that being said, an alternative helmet is really great for those kids that can't handle the weight of an equestrian helmet.
So one of the things, though, that we as a collective group need to do is, so much of the guideline surrounding helmets is related to horseback riding. It is not related to treatment, medical treatment, incorporating equine movement. And we have a role, we all need to not blindly accept a piece of equipment that's actually, you know, as the standard for everything. And we need to voice our concerns more comprehensively, explain where those helmets can do damage, and remind everybody all the time that we're doing a therapy session. It is apples and oranges from me getting on a horse and going over fences or racetracks or out on the trail.
Yep.
And I think that's part of why this discussion is so important, because if you're a non-horse person, it's easy, you want a simple answer. It's like, oh yeah, let's just put a helmet on. Everybody makes me feel safe. And nothing, is there any one thing you use for every single patient that you treat? No. So this is why this discussion is so wonderful.
All right.
I have a non-helmet question, is that all right?
Yes, go for it.
I just wondered if anybody has a resource of gait belts for little tiny people.
I found one on Amazon that's like webbing and it's handles I like, and it was too big to fit on my littlest ones, so I took it to a cobbler.
Okay.
And he cut it, he has a heavy duty sewing machine, and I told him I wanted sewn in a square and next, so I secured it, I drew what I wanted, and had him modify it for me, and now it's on even kind of a kid who's like, just turned 3, and he's like, but it's there now.
A few conferences ago, there was a vendor that had, what was the name of the belts that he sold?
I grabbed one of those.
The grab handle ones?
Yeah.
And the pediatric size?
Elgin is what we use for the small ones.
Which one, which?
Elgin.
The L-line.
They get pretty small, so they come functionally, but they're still pretty small.
They are
so
tall.
don't need
Yeah, that's where I read.
child's trunk is.
Okay, thanks, sir.
All right, so I'm going to go ahead and switch us over to gait belts. What do you guys think? Can we establish clear guidelines on when to use a gait belt, when not to use a gait belt? Yeah, so always use one unless there's a contraindication, right? And of course, if there's a contraindication, you're probably not using equine movement anyways. All right, I think that's pretty clear set. Especially from a liability standpoint. I know there's a lot of people out there that they're like, I don't like putting a gait belt on my patient. I think it interferes with the movement. And honestly, it's a handling skill set. You've got to learn how to handle that gait belt and not have it interfere with the movement. And it takes practice and skill. You can ask any of the PT students that I've mentored. It takes time and practice to really get that skill down. And there's no shame in it. There are still days that I'll catch myself and I'll be like, oh my gosh, I'm doing terribly today. I need to adjust my hand positioning. But there are times that you get really skilled at it, and I can have a very sensory defensive kiddo. I've got one in mind in particular, and we'll be going around, and I'll have a hand on one of the handles, and she won't know I'm there, and we'll be 20 minutes into utilizing equine movement, and she'll suddenly, look back to see like what her twin sister is doing or something. And she'll look back, and then she'll notice my hand behind her, and then she gets all offended. And it's like, I've been there for 20 minutes, darling. But she didn't feel me there because I wasn't interfering with the movement. But like I said, it takes practice and handling skills. Yes, Matt?
I was going to say, for those sensory defensive clients, what I found that works really well is to give the parents the ability to go purchase that, and then they can practice at home, and even come to the therapy session already wearing the gait belt.
Yes.
You don't have to battle with putting it on.
Exactly. That's a brilliant idea.